Okay, so thank you for joining us today. This is our cup of tea event, which is like a journal club. This is it happens quarterly. So this is our first of the year event happening in March. Our next event will be happening in June. So if you found us this time, come back in June as well. And I'll let you know about other events that are happening. So I'll be your host for this event. My name is Ivana Rostevsky. I am a parent working in Helen Damaris's lab at Sick Kids, and I'm a mom of a retinoblastoma patient who's 10 years old. So I got interested in being involved in research because I wanted to learn more, just like a lot of other parents want to find out more information, want to understand the information better. And so by being in the team and being involved in research, I feel like I can work with people who will answer questions and I can discuss research with, and then also offer my feedback on research based on my lived experience and my son's experience. So for our event today, I'm just going to go over some announcements, and then we're going to dive right into our article summary and have lots of time for a community discussion. This is a important topic for all of us, so I've tried to make as much time available to us today. So anyone here who came because they got an email or they got our newsletter, you're in our retinoblastoma research community. If you did not get the newsletter that came out beginning of March, then you can join us. So the retinoblastoma research community was created to connect people who are connected to retinoblastoma, either personally or professionally, and who are interested in research. So everyone who's here today can sign up if you haven't already. The link will be shared in our chat. So open that window and you can complete the sign up after our call, or it's just a quick 5 minutes. You can find more information about events like this and other things that we're working on our social media. We're on X now, not Twitter, Instagram and Facebook, with the different handles listed at RB_research for X and Instagram, and at RB Research for Facebook. If you are already in the community, you could share this information with others. If you're a researcher or a health professional, share with the families that you know and other colleagues. You could share the link to our website for them to join or invite them to a future event. And same with those who are connected personally to retinoblastoma, share the information to people in your network and invite them to future events. Okay, we do have a study happening right now that most of you have heard about already. I've mentioned a couple of times in our previous events. We are looking to find out more about the psychosocial needs of RB patients and families. If you've already filled out the survey, you could share it with somebody else. If you haven't, you'd be helping us out to learn more about the psychosocial needs of patients and families so we know what supports they need and to offer them. So the questionnaire can be filled out by retinoblastoma patients or survivors over the age of 16 who had at least part of their treatment in Canada. You could also email retinoblastoma.research@sickkids.ca for more information about this study. And the most exciting event that the Canadian Retinoblastoma Research Advisory Board is hosting is our 2024 Retinoblastoma Research Symposium. So big and exciting event happening April 20th and 21st. There's 3 in-person locations, Vancouver, Toronto, and Halifax, and also offered virtually over Zoom. Anybody who has lived experience with retinoblastoma, so patients, patient families, survivors, we have a limited amount of modest travel stipends to help support your travel if you're traveling into one of the in-person locations. And you could indicate that when you register, and that link will be shared in chat as well as our website. We have more information about the event. And any parents who will be attending virtually, if you register this week, you'll be receiving a free child life package for your children to work on while you're attending the conference, the symposium. Some upcoming events that are happening. The blue are our Canadian Retinoblastoma Research Advisory Board events, and the pink are our friends. So we have the Retinoblastoma Research Symposium, April 20th and 21st. June, we have our CRBS Canadian Retinoblastoma Society Family Picnic, June 8th. And then the next cup of tea, as I mentioned, is happening June 18th, and we'll be focusing on 3D printing technology. Oh, sorry about that. We'll have our quarterly general meeting, and just highlighting that the 1RB World Hawaii is happening October 15th to 17th, and I'm calling that out just so people can register, and that registration's open. So please register. The link for more information is shared in our chat. And ongoing events from OPAC, they have the parent drop-in at the Sears Clinic, 8th floor, Monday, Wednesdays, and Fridays at Sick Kids Hospital. Okay, so we're here for talking about a plain language summary of a research article. And our cup of tea today is going to discuss the article Recommendations for Long-Term Follow-Up of Adults with Heritable Retinoblastoma. The plain language of this article can be found on our website, and this plain language was created by our team here, Ella Bowles and Dr. Dan Gombos. So you can find it on our website and read it and follow us along as well as we present. So Dr. Ella Bowles is a bilateral retinoblastoma patient. She is also a doctor, but in the area of biology with Environment and Climate Change Canada. And with a recent health concern and some patchy medical records and no access to consistent family physician or follow-up, Ella felt that it was time to really get to know what symptoms to watch and advocate for. And this brought her back to CRAB and to revisit some of the work that she did before, working with Dr. Galley, where she was helping to write the Canadian National Retinoblastoma Strategy, and was one of the early CRAB board members. So she's currently a biologist with Environment and Climate Change Canada. And I met Ella when she presented at a previous retinoblastoma research symposium where she talked about her retinoblastoma experience. And Dr. Dan Gombos is the professor and chief of the section of ophthalmology at MD Anderson Cancer Center and the clinical co-director for the Retinoblastoma Center of Houston. With an extensive resume of training and experience, Dr. Gombos' clinical, surgical, and research interests are in the area of ocular oncology, in particular focusing on the management of retinoblastoma, uveal melanoma, intraocular and conjunctival malignancies. And the first time I met Dr. Gombos was at Washington at the 1RB World Conference, where he spoke to a group of patients, health professionals, and researchers about retinoblastoma. So here we are today, and I'm going to get started by passing it over to Ella to begin her presentation.
Thank you very much, Ivana. Thank you for organizing this, for giving me the opportunity to explore something that I feel I need to. And yeah, I think it's a lot of work to put these things together. So thank you to you and everybody who helps behind the scenes. So on this first slide, if there's anybody here who can't see it, I just have a image of the right side of my face with sort of light focused on my prosthesis to sort of, I guess, maybe shine a light a little bit on something that I guess I've struggled a little bit to highlight and perhaps is less highlighted in general. So just to sort of play with the idea a little bit. Okay, next slide, please. And Ivana so beautifully kind of provided a bit of a layout of and suggestions for the order of this presentation. And she included a spot for my story and why I'm here. So I'll start with that. So as she said, I had bilateral retinoblastoma. I am currently 42 years old. And so, obviously had this a long time ago. And I have one of the more common mutations in the retinoblastoma gene. So my right eye was enucleated fairly early on, but I had tumors until I was about 2.5 in my other eye and had cryotherapy and xenon arc as treatment. So for those of you who are a bit newer, xenon arc is, to my understanding anyways, kind of the precursor to what is now to laser rather, which is used currently. And if there are any ophthalmologists on the call or somebody who would like to correct me, feel free to speak up now or later. So I think important to my story and the reason that I'm here is that I have moved around the country a lot. I currently live in Ottawa. I'm from British Columbia. I moved around British Columbia a lot, a fair amount anyway, as a young child with my family. And then since leaving home for university, I've crisscrossed the country several times. And for periods of time in my life have had consistent access to kind of a family physician. And, perhaps they have sort of a longer track record of some of my records. But despite substantial effort, I have really patchy records, medical records. And as you know, retinoblastoma is a complex disease with complex treatments and where treatments can impact kind of outcomes later in life. So also, I think importantly, I have had consistent ophthalmic care. So throughout my life, regular, predictable, and of course, an ocularist for my prosthesis, but no other follow-up care, such as an oncologist. Next slide, please. So early last year, I started developing lumps around my neck. I now have about 8 of them. And, with some previous experience in retinoblastoma work and literature from many years ago, I sort of, knew enough to kind of be a little bit concerned about those lumps. Since I've been in Ottawa, which is, I don't know, I guess coming on close to 2 years now, I have not been able to get a family physician here. And, perhaps in part as a consequence of COVID and changes in the primary care system, access to a family physician in general is just really difficult. Even through a walk-in clinic. It takes about 4 or 5 hours, I've found, since, when I arrive, when it opens, to get in. Having already kind of experienced this for other things and sort of having some knowledge of retinoblastoma, I chatted with sort of physician friends and mentors in the RB community and asked sort of if it was, if they felt that maybe I should get these lumps looked at. The answer was yes. After that, it took me 2 or 3 visits to the walk-in clinic explaining what my predisposition was to my knowledge to kind of convince a GP to refer me for imaging. And so I didn't sort of take in my stack of patchy records, but I could have, and I felt like maybe those wouldn't even have helped. So sort of because of that experience and like a little bit of a scare for me, sort of knowing that my chance of secondary cancers was higher at my current age and going forward, I felt like, okay, now's the time to kind of get back into the retinoblastoma world and really kind of get to know, to really know for myself, really what my risks are, what is indicated for surveillance for me, and kind of how I might advocate. So I've sort of come back to the retinoblastoma community to to explore those things. Next slide. So this was kind of the perfect opportunity with this cup of tea to explore just that. Really fantastic article in my view. So we're just going to jump right in. So because there's some sort of pretty complex terminology in the article, I'm going to define some things here. We don't really use these terms mostly in this very brief presentation, but just kind of to make them known, I guess. The kind of key ones here are germline mutation, which are changes to the DNA that happen in the reproductive cells of the body. So if one of the parents has a mutation, it can be passed on to the next generation and would affect all the cells of the body. Unlike somatic mutations, which do not affect the reproductive cells and are not passed to the next generation. So these are the two main types of RB1 gene mutations among the RB population. Heritable retinoblastoma is, of course, the passing on of the mutated gene to the child, and subsequent malignant neoplasms, which Ivana and I agree does not roll off the tongue very easily, are the development of a new unrelated cancer later in life. So secondary cancerous tumors, which can spread into nearby tissues, are malignant. Benign neoplasms are not cancerous growths and do not spread into nearby tissues. So I'm probably going to just refer to second cancers. And then dysplastic nevi, this term was new to me. This is a mole that looks different than usual and may develop into melanoma and should be looked at by a health professional. These moles have irregular edges and are larger in size. They can range in color, they may be raised, and they are also referred to as irregular moles. And a sarcoma is a broad term for a cancer that develops in the bone or the soft tissues of the body. Soft tissues include cartilage, fat, muscle, blood vessels, fibrous tissue, or other connective or supportive tissue. So I should say that there's like brief definitions on this slide. The plain language summary, which actually Ivana did a lot of the work on, goes into more depth, but is still really in plain, it's very plain language. For me, I found the article to be pretty straightforward too. I have a little bit more scientific knowledge, I guess, than the average person, but that's kind of, anyway, I think it's pretty accessible if you want to go there for even more. Okay, next slide, please. And so, again, I would say that the article is pretty straightforward if you wanted to, go there to get a bit more depth. But so we'll just provide like really, what we feel are like the highlight pieces from the paper, so that we have lots of time for discussion and for Dr. Gombos to talk about some important kind of pieces, I think, that are take-home messages from the paper. So basically, RB survivors with a germline mutation have increased risk of developing a new unrelated cancer later in life. The risk is higher for those who had external beam radiation. Also importantly, so surveillance of RB survivors varies with context within each country with no universal guidelines available. So that led, next slide, please, RB health professionals from around the globe to conduct this evidence-based review of the published literature to assess what risks exist and kind of establish some best practice. So it's a really, comprehensive and high-powered article, and I'll ask Dr. Gombos to talk about that a little bit later. Kind of just in general, the authors used a grading scale to establish the level of risk. So, a grade of A is like very high level of risk, B less so, C less so. Next slide, please. Yeah, perfect. If you look at anything in this paper, table 1 would be the highlight for me. I think it's just extremely clear. What we have listed here really comes directly from table 1. So they list what second cancers survivors are at highest risk for and kind of go down that level of risk, and then what is recommended in terms of surveillance. So here we just present the highest risk and the recommended surveillance, but there's it's all there in the paper. So there's very strong evidence of risk for bone and soft tissue sarcoma, which I was very proud of myself. This is what I had remembered from many years ago and the knowledge that I had. So I was like, okay, that checks out. And then also melanoma and uterine leiomyosarcoma. There's strong evidence of risk, which may be limited to those with a history of radiotherapy for bone and central nervous system tumors. And there's moderate evidence of risk for breast cancer after the age of 40 years. So that's me, and also lung cancer. Next slide, please. So in terms of what they recommend strongly, this includes annual skin examination, especially those with dysplastic nevi. So those are the irregular moles. And there's a moderate recommendation to do an annual history with a physical exam with attention to bony structures, and prompt evaluation of signs and symptoms, of course, such as persistent sinusitis, pain, or skeletal tenderness. And I can't remember what sinusitis is. I'll say that everything, so if anybody kind of can't see the slides, I meant to say this at the beginning, but I'm basically saying everything that's on these slides. So there's kind of no information that's, that's kind of presented on the slides that I'm not also kind of covering verbally. Next slide, please. Yeah, right. Okay, so an important point that we thought to highlight is that there's really a lack of evidence for surveillance of most second cancers. However, there's, of course, a call for more surveillance studies. As a patient, this paper was extremely helpful to me. I feel like it does give me a part of my toolbox. It tells me, what I need to pay most attention to. I will take table 1 in with me to my next walk-in doctor appointment, if needed, so that I can kind of, demonstrate, the evidence behind what I'm saying. In fact, I'll probably take the whole paper with me. But it does still leave me with some questions, which maybe we can explore kind of in that question session. At this time, I wonder if I can call on Dr. Gombos to talk a little bit about why this study is kind of a powerful study, and then any kind of highlights for him in reading it and things that he feels should be conveyed.
Well, thank you, and I'm very grateful for the opportunity to be part of this. I think this is awesome that you guys meet together, identify manuscript in the literature, sort of decompress it, make it palatable. It really is an empowering thing. And when I was presented with various options, I thought this was such an opportune paper to discuss for many reasons. Before I get to that, I just wanted to make sure we quashed 2 questions that might have come up. So xenon arc is a very old form of laser. So think of xenon arc as an old laser, and there's actually one of the old xenon arcs still in Memphis, Tennessee, in a museum. So if you ever want to see one, it was there, and it was, as Dr. Galley knows very well, was one that Bob Ellsworth used and Reese used, and really was transformative in, if you like, focal treatment of retinoblastoma in its day. And the term that you were looking for is sinusitis, so any sort of inflammation of the sinuses. That may be postnasal drip, it may be bleeding from the nose, but any sort of inflammation. Those were just in case those questions sort of came up from your prior discussion. Why is this paper so significant? Well, first of all, it is very relevant. Sometimes when you have a paper in the manuscript and the literature, it's hard for people to say, how does this impact me in my day-to-day life? And the first thing I would say is that this is a manuscript that actually tries to have pragmatic, detailed recommendations to healthcare providers about what to do, what to recommend to their long-term patients with heritable retinoblastoma. To backtrack a little bit, we as a profession, I think we do an amazing job with retinoblastoma, right? A disease that has 98 to 99% cure. The challenge that I think we still can work on, and an area for benefit, is once we've cured that family of retinoblastoma, right? Because it's always about the family, it's not just about the patient, is transitioning that patient to the next phase in life. So when they're done at age 6, 7, whatever that age is, and they've been deemed cured of retinoblastoma, that transition to adulthood, and to make sure that those families now understand that their journey with retinoblastoma doesn't end when we've cured retinoblastoma. because the clinicians, particularly ophthalmologists and cancer specialists, all know that patients with heritable retinoblastoma carry increased risk of other tumors. That's because the importance of that retinoblastoma gene is important and ubiquitous in developing of other cancers. So some of the comments made about the known risk of sarcomas, soft tissue and bony sarcomas, the known risk of skin melanomas, clinicians in this field know those risks. But not everyone who doesn't manage retinoblastoma day to day will appreciate those risks. So I think, any expert in the field will know this, but maybe a GP who doesn't routinely interact with an RB patient, they may not. And it's important to sort of, if you like, bring to their attention the importance of being proactive and advocating for patients who are at higher risk. If you're fortunate enough to be in a big cancer center, to be in an institution or a city that has survivorship clinics or surveillance clinics for high-risk patients, usually practitioners will know about, the cohort of retinoblastoma and their need. So why focus on this paper? Well, when a clinician knows you have an increased risk, then how does that translate into an actionable item? And a lot of times different individuals different centers may have different recommendations. They may say, okay, you're at increased risk for skin cancer. I say that you have to have a full body skin check every 6 months. Well, where's the evidence that those recommendations make sense? So the purpose of this manuscript was to take a series of people who have very vested long-term work in retinoblastoma. And there are many prominent people on this manuscript, people like David Abramson and Ruth Kleinerman and Annette Mall, who have, large databases, who have looked for generations at risk of these other tumors, and say, where is the scientific merit in making certain recommendations? Not just what does a doctor think, but where is the scientific proof that certain things are beneficial for patients with heritable retinoblastoma versus not? And let's go through the literature and see what science tells us we have scientific merit. And there are criteria with which we can do that. So it's not something that this paper had to invent. There are better scientific papers than others, and there are certain scientific areas where the literature supports certain things. For instance, there are some doctors who for many years have advocated getting routine MRI scans on the long bones. There are centers that have advocated that. Well, this paper tries to look at what is relevant and scientifically validated to do. And the bottom line is that really the most scientifically valid thing that they say you need to do is an annual good physical exam, very important. If you know you were treated with radiation, you definitely need to have a low threshold in the field of radiation if anything is atypical. So again, radiation usually would be applied to the head and neck area. We don't do that very much anymore, but on rare occasions, sometimes we still do today. If there are any lumps or bumps, if there's any swelling, if there's any chronic inflammatory problems, you should check that out immediately. And because of the risk of skin melanoma, if you have a bad looking mole, you should really not ignore that. There is a lot of scientific value to have that checked out medically. And basically what they're saying, anything else that people have done, MRI scans, etc., there isn't the science that proves that's beneficial. Doesn't mean it's bad. Doesn't mean that you shouldn't do it if your doctor says do it, but it says that the science at present doesn't support that as a routine recommendation. And this is a very palatable paper. I mean, as Ella was saying, this is a paper where you don't need to have a lot of scientific background. And there's a table, and it's referred to as table 1. It's on the 3rd page of the manuscript. If nothing else, just read that, because it is written for a medical background, but you don't need a medical background to understand its recommendation. And would strongly recommend someone who isn't in an environment where they can go to a surveillance clinic, or they may be having a primary care provider or a GP who doesn't know a lot about retinoblastoma. You can definitely bring this manuscript to them. This is the kind of thing that you can say, look, these are recommendations from world experts, and they say if I have a funny looking mole, I need to get it checked out. Or if I'm having chronic nosebleeds and I was treated with radiation for my retinoblastoma, I need to have that checked out. And that can't wait 6 months. That needs to be checking those things. So there's a comment from Kate Payton, and thank you, Kate. It's always a pleasure to see you and all the other Canadian retinoblastoma clinicians out there who are on here. Let me see, what did Kate say? So assuming the individuals, and yeah, so there are things, of course, you can empower yourself doing. If you know you're at risk for lung cancer, obviously you don't want to smoke. If you know you're at risk for skin melanoma, you don't want to get a sunburn. Those are certainly things, but this paper focuses more on surveillance things that you should be doing, your doctor should be doing. So I think it really is something that I think Ella walked away saying it's a helpful study for her as a patient. I would say for any parent and for any individual who's a survivor, this is that kind of paper that you can say, oh, this paper can really impact my life and has a direct impact on me for the following reason. I think that's why we chose it for today's discussion. So I'll stop there. And
Dan, can I ask you to speak to one more thing?
Yeah, of course.
That we talked about in our discussion last week?
Yeah.
We were talking about how, there's no standard guidance sort of, within a country, across country, let alone within a country. So, this has kind of provided a guideline for, what's important to monitor. Can you speak to the regional context at all and how?
Yeah, it's a great thing. And actually, I'm going to quote from the paper for a second. And because they often say things like, and I want to use the term correctly, they use the term, I think, regional recommendations.
I think that's right. I think that's
yeah. I just want to make sure that if it, okay, sinusitis. So I think here's what they were getting at. This is a paper that includes individuals and experts from around the world, primarily North America and Europe. And I don't think they wanted to say everybody needs a skin exam once a year. They didn't want to say you have to be seen by a dermatologic Mohs surgeon whenever you have a funny looking nevus. What they wanted to say is there's evidence that addressing these issues promptly makes sense. Now, in some countries, that has to go through a GP, and that's okay. In other scenarios, you may have direct access to a surveillance program, and increasingly many retinoblastoma centers have long-term survivorship programs. That may be the mechanism that works in that country. There are European countries where they'll have their own standards. So they didn't want to create a system where they said, once a year, everybody needs to do this. So they didn't want to constrict people, especially when a healthcare center says, otherwise you just get an exam once a year. But I think they wanted to create an environment to say whatever is a local standard in your country is an acceptable one. Understanding, I think that there's an inherent bite that a lot of these are written toward westernized healthcare systems. And there's enormous variability when even we look at North America due to the rural versus urban nature. It may be a province-related difference. Again, within Canada, in the United States, it's often our health-based case system, which is very state-based from that perspective. And as Dr. Payton points out again, a lot of pediatric cancer hospitals have established programs to help with that, but not everyone is in a city where that exists. So I think that's why the recommendations were written in such a way that they would not inhibit or force a clinician to say you must do this. Nonetheless, I still think it has a lot of very important data for the patient and their family, especially if you're like, it sounds like Ella was having to fight with the system and the GP and
Yeah.
justify why she is a higher risk patient, and something like sinusitis, which may not be a life-threatening thing for the average patient, in this cohort, it might be something that is very significant. So I think the nice thing about this, as I read this, is I also see this as a patient empowerment paper, because sometimes to get through the system, you need scientifically validated papers to say, this is what is appropriate for my care based on and this is also published in a high impact ophthalmic journal. This is really the gold standard for North American healthcare within journals of English speaking journals.
And the quality of the methodology. And I would say, and the quality of the methodology is very, very high. I think you spoke to that. And I would say that is exactly what it is to me. It's a patient empowerment article, and it's exactly what I needed, I feel. Anyway, we've talked a lot now. Sorry, Ivana.
No, this is fantastic. And then you guys have really summarized the article very well. And maybe we could turn the screens over to our attendees here, and we can have a community discussion. Well, we've posted some questions on the screen, and while you guys read through them, I have a group for those who have lived experience. And just a reminder, those are those maybe parents, patients, survivors, and professional experiences are all you researchers and health professionals. So as you're thinking of what to say, we have a question posted in chat already from Claire asking, has it been observed that frequent imaging, example MRIs, increase risk of other cancers in terms of radiation?
So they sort of address this. First of all, they make very clear that they recommend non-ionizing radiation exams. So that's why MRIs are thought not to have ionizing radiation. So that's why it's often used in the RB cohort. There has been some back and forth discussion about the long-term use of gadolinium. Gadolinium is a dye. Some people have questioned its potential toxicity. Other studies have questioned that or have said that that's not as much the case. But I think the biggest reason why, and clinicians really do see this concept of false positives. So a test shows something. Then as a result of that test, you get more tests. Maybe you get a biopsy. Maybe and it turns out to be nothing, or it turns out to be something completely normal. So clinicians are put into check to say, just because you're doing a test doesn't necessarily mean it does not come with harm. All tests are not necessarily beneficial. And without that scientific validity, this paper did not come to conclude that, you should be getting MRIs. And they even acknowledge without that, there is the potential that even routine screening with an MRI could bring with it some harm by inducing a lot of unnecessary false positive testing. So these are just, sort of concepts that exist that, screening someone does not come without inherent risks as well. We're trying to find benefit, but we need to think about that. But, and it doesn't mean that you never get an X-ray, but we're talking about screening exams using non-ionizing radiation. So I think there is pretty good consensus that we do really want to avoid ionizing radiation if we can, particularly before the age of 1 year in patients with known heritable retinoblastoma. And we used to do CT scans routinely as a baseline exam for retinoblastoma. We don't do that anymore, at least most centers don't.
Thank you so much for the answer.
Perfect. Does anybody want to share their experience or talk about their understanding of the article and second cancer risks?
And I encourage everyone to look at the chat, because Dr. Payton's putting some great recommendations in the chat. And it would be really helpful to, for individuals to see those comments.
We have another comment in the chat saying, Ella's experience of having to fight to get appropriate care is not isolated, as some might think. One would imagine that bearing letters from both Dr. Galley and a genetic counselor detailing the specific RB mutation and cancer risk would be enough to have doctors take a patient's concerns seriously. That hasn't been my family's experience. Do you have any other suggestions for getting medical personnel to listen and follow up appropriately?
I can't speak for the Canadian healthcare system, but when I've had to fight with US insurance providers, manuscripts like this are a significant thing, especially if they're written in a high-level journal and they're written to provide practice care guidelines with the intent. So I think that's a place to start. Certainly when you're fighting with insurance companies and probably the healthcare system, but there's nothing like advocacy from retinoblastoma experts that you have in Canada to be an advocate for you. That I'm sure that goes a long way. Dr. Payton?
I think there's a couple of different ways people can assist. The reality is variable from place to place. I had a head of a cancer agency tell me, oh, family doctors can do this. They can just go to their family doctor. And we have a late effects clinic, not at the pediatric hospital, but when they age out of there, this is based at the cancer agency because it's just not appropriate to imagine that the family doctors are always going to know. And I think if there's a centralized place for care, in this day and age when pandemic has shown us that we can do telehealth and we can do other forms, we should be looking at personalized plans. So in my mind, there's at least three things. One is what's going on with the patients who are currently being looked after so that they get to track through. The second thing is what about the extended family members? Because there may be somebody in their family who's had retinoblastoma, but their care was never provided here. And having some basic information and exposure information to what drugs or what radiation in what institution at what doses is somewhat helpful. And then having advice for people who've immigrated, because people move. We don't even have a system where you can necessarily move from one place to another, one province to another, and port material over just yet. But before I'm done, I really hope that that's where we get to. Our LEAF clinic has been partly driven by a radiation oncologist, senior member of the team who saw all the childhood radiations for other things as well as retinoblastoma, but who was able to fold retinoblastoma into that grouping. And I think the terminology and the funding and the system, if you like, when there are patient groups to be advocates for uncommon diseases, can work at that and be successful, particularly with papers like this, which tell you you don't have to do everything. I'm not very happy with a rubber stamp that says everybody should have everything and quotes all of the risks. It would be nice to see those things more personalized. And I hope 10 or 15 years from now, that's what we're doing for everyone, because we should be able to go back and watch. Won't mean that everything gets detected early, but when patients raise a problem, it shouldn't have to wait to get to a center that knows what to do. Should be a pipeline. And some of those referrals don't have to wait to go through the family doctor. Again, if they go back through the retinoblastoma clinic or the late effects clinic, then you're not sitting waiting with everything else that might or might not be important. Because I think you won't ever have all the family doctors or nurse practitioners who are providing primary care up to speed on these things.
That's really great information. I have a few questions in the chat, but before I get to those, I see Bruce has his hand raised.
Thanks. I think Brenda had her hand raised before me.
Oh. Sorry, Brenda, would you like to go?
Yes, I'll be very brief. There is a long-term follow-up clinic run at Princess Margaret Hospital by Dr. Bruce Hodges, who's a pediatric radiation oncologist and particularly specializes in follow-up. But most of our families, members are not aware of that, and it's not very widespread. So I just have a little suggestion for all of you. Our Canadian guidelines were published in 2009, and we need to revise them, and we should have a whole section that we work together for follow-up so that then every family can find the access locally. Over to Bruce.
Well, thanks very much. Just to say that from a pediatric oncology world as well, because there's a lot of ophthalmology people in here as well, there are two really good resources there for survivors of childhood cancers. And one is the Children's Oncology Group Survivorship Guidelines, which is freely available. I can put that in the chat. But that is an incredibly huge, comprehensive, evidence-based guideline that's updated every few years. I think they're onto version 6, I think, at the moment. And that will tell you if you've had this particular type of treatment, this is the surveillance that you need. And you can sort of pull out all the different bits and pieces from that. It's very, very useful if you're actually within a long-term follow-up clinic or anything like that, that the physicians, the nurse coordinators, the nurse practitioners, they can help you to steer through that. And then the second one is that there is another service that's kind of sprung out of that called the Passport for Care program, which is an online service, again, which incorporates those guidelines. And at the moment in Canada is accessible really through the pediatric oncology. But what happens is that you upload your treatment summaries and things like that into it, and it will generate recommendations for ongoing surveillance for you. But that is also yours. You create the account and the information is uploaded to you. And that is portable because it's cloud-based. And so wherever you are in the country or wherever in your world, you can access that information and access those recommendations as well. All of the children's oncology centers, so the 16 centers throughout Canada, have some version of a long-term follow-up clinic. As I say, some of them go into adulthood, like the BC one, like Edmonton, like Ottawa, but some of them, like ours, doesn't, because we don't have the resources to do that. But if you access them, they can help to sort of give you some guidance as to where you need to go for certain things. So those resources are certainly out there, and I'm more than happy to help people. Excuse me, I've just been catted. So this is what you don't want. This is what you don't want. You don't want a CAT scan, because CAT scans are radiation. You very much like an MRI scan, but this is your cat's eye. And this is Eve, and she's being very, very beautiful.
It's a beautiful cat. I have a question here from Charles asking, does sick kids, or we could ask anyone from any other center, have a program to prepare RB kids and families for the transition to an adult long-term cancer surveillance program?
We don't have anything organized, and I think Bruce is way ahead in his recommendations. I don't think Sick Kids has done anything along this line in an organized way.
You know, I think the field is evolving. It is increasing. You talk about meeting some of you in Washington. It was clear that, you know, like many other pediatric cancers, the field is oriented towards survivorship. That's such now a hallmark of pediatric cancers. And so most retinoblastoma groups embrace that. And then at the same time, adult cancer centers usually have surveillance for high-risk patients for various genetic predispositions. So I think it's that bridge that's still sort of in the process of, you know, evolving. The biggest challenge for those of us in North America, I don't know how much is in Canada, is the transition in healthcare. You're a child, you get healthcare because of your parents, and then when you're an adult, you have to sort of figure out your own healthcare system, and that may not be relevant in Canada, but I think you know, that's sort of something. It's also natural, as you might imagine, that when you're done with your cancer and you're cured of retinoblastoma, the last thing you want to think about is other cancers that you're at risk for. And so I think most centers now increasingly, when you're done, say, well, you're really not done. You have to be part of a survivorship clinic, at least in the pediatric part. And then hopefully as patients turn 18, they get transitioned or maintained in that clinic. And I think we're evolving, but that's increasingly the standard from RB throughout the world with that understanding. Just like genetics is now the standard. You know, when Brenda Galley was doing genetics in 1970, who thought about getting a geneticist for every RB child? And now you get a genetics evaluation as a standard of care. Well, that's the same thing, I think, with survivorship.
That's really great information. We have another question asking about RB mutation. So the question asks, would the RB mutation ever change as a child gets older, since the child carries the RB mutation? I was always told that she has a 50-50 chance to pass it on. Is that correct? And if I may add, anyone of our health professionals or researchers answering, if they could touch upon any other aspects of RB and how second cancer affects them, just so we can discuss that part with our community. Maybe thinking about 13q deletion patients, and if any unilateral patients have the same question. I think they might. How are the risks different? And then answering the question of would mutations ever change?
So should I answer that? The RB mutation that your daughter carries will not change. It will be there always, and that's why she has these risks for a second cancer. But her children, passing it on means that half of her children, 50%, will inherit the chromosome that carries that pathogenic mutation in the RB1 gene, and the other half will have her normal copy and will not get retinoblastoma. So you're quite accurate in 50-50 chance for her children, but her mutation itself never changes. It sits there. It's part of her. We can't take it out, can't fix it yet.
Well, and I think another important point is just because you're unilateral does not mean that you're not necessarily heritable. You need to be assessed. So that's a very important point that I think even some clinicians, and I've seen pediatricians tell parents the child had unilateral disease, meaning one eye was involved. You don't need to worry about these things. That's not necessarily true. And that's an important point, and that's why we have geneticists, and that's why we have genetics evaluations, because if you are heritable, these are the time, that's why the paper is written of adults with heritable retinoblastoma. It didn't say bilateral retinoblastoma, it said heritable, understanding that a small percent, but a relevant percent of unilaterals still may have heritable disease, and they carry these risks and these recommendations.
Okay, we have about 5 minutes left, which is enough for maybe 1 or 2 questions. We have some extra questions saved on our next page if anybody is interested to discuss further. Any questions about how to better understand your risks? Any more questions about whole body MRI imaging? If there anything was unclear that we've discussed so far? Or is there any surprises that we've discussed that wasn't, maybe you weren't aware of before? Or anybody would just like to share their story and their experience? Michelle was mentioning in the chat how she has going through the process of moving her care from the US to Toronto. Would you like to share something about that, Michelle? I don't want to put you on the spot. You can say no.
Sure. Hopefully, I don't overlap too much with the session. Unfortunately, I had to come in kind of during this Q&A portion, due to a schedule conflict. But yeah, basically, I was treated in the US, and I've been living here for a few years. And since I'm still on, like my parents' insurance, I have been going back for my annual visits still since, my care team was familiar with me. We could like Fortunately, the insurance that we had helped out with travel, things like that. So, as I've kind of been more established in Toronto, as there's an interest in like switching things over here long term. And I guess right off the bat, one of the bigger like barriers in the way was accessing my own medical records. Um, so sending them over to another clinic. I don't know the timeline for that since I don't think they've been sent yet. But even requesting a personal copy, which, I was under the age of 3 when all of this happened, they charge per page. And I had asked like help information, basically, how many pages would we be looking at here? And they're not permitted to give that answer unless I sign the release form agreeing to pay that amount. So I haven't quite gotten a solution to that yet. But yeah, like access to records has kind of been an interesting thing that's come up. Otherwise, it seems, especially when family doctors are less experienced or haven't maybe seen somebody with like hereditary cancer syndrome before, since I've the bilateral RV, who to refer to and like what that process would look like for different specialists is also something that's come up. In terms of the whole body MRIs, that was something that I had done, I want to say maybe like in the 2010s for a few years, and that was something that had kind of stopped. But yeah, it's been a work in progress. Yeah, I know, a bit of a unique experience, but
Good luck,
yeah.
Michelle. Good luck with that. I hope the charge doesn't become too much, but with so much care that goes into retinoblastoma, I'm not sure how many pages they might be wanting to send.
Yeah, I have an idea. It's quite a bit. Fortunately, I don't think they charge for sending to other clinics. So, yeah.
This is where Brenda's lovely summary on Depict Health would be so helpful, would give you the info you needed and not be huge pieces of paper.
Yes, so the Depict Health will someday be someday soon. We say 2024, but it will collect and it will retrospectively be loaded for centers like Sick Kids or a Dan's center in Houston may join as a site, retinoblastoma site, and put their patient data in. We will be able to retroactively load data. So for Michelle, if we had the data from your center in the right format, it could be ultimately loaded into Depict Health. But the Depict Health is just a database that will be on the cloud for every retinoblastoma site in the world to join if they choose. And the patients will consent to have their clinical data in Depict Health, which is on the cloud. It's not in the site that is the custodian of their data. And the site would agree to support that use of Depict Health. For research to be used on that data would be a separate consent from the patient and family to use their data for research. And there's a whole pathway for that to ultimately use every child's data to generate the evidence that's missing and in many ways for going forward to continually have a process to develop new technologies, new evaluations to serve the world better for retinoblastoma patients. This will get close to being launched in 2024.
That's fantastic news. We're looking forward to that. So we're at 9 o'clock now. I just wanted to highlight, we were talking about that table 1 from the article, and that was what Ella had shared in her slides. So we looked at it, just not in that format from the article itself. If anybody has trouble accessing the article, I think those with at a center can access it through their institution. But if you not try and access it through a center or institution, email us at retinoblastoma.research@sickkids.ca, and I could work with you to get you a copy. And if you have any questions, email me, but otherwise, I know some people have to go to a second meeting. And thank you all for attending this meeting tonight. Thank you to Ella and Dan for presenting and sharing this information and educating us on the second cancer and screening practices and what we should be looking for.
And I just want to say thanks very much to everybody who's here, and to Dan, and to those who have provided information. I've learned even more this evening, and we'll be following up with various folks.
And could I just say quickly, Michelle, I would really like to talk with you more, because what you've said and described the difficulty with your records will really help us to raise money for Depict Health.
Oh, yeah, for sure. I can send you an email.
Good.
And your experience, Michelle, is not like this is exactly my experience. I mean, the cost, like, it's maybe not the same in Canada, but it's still, it's still money and time, and yeah, it's a very common story.
Yeah, I'm fortunate that like transferring them to another doctor or like clinic doesn't have a cost, but for, requesting a personal copy, it's by the page, yeah.
Well, transfer them to us, Michelle, and then we'll give them to you for free.
Thank you. Yeah, I'll be in touch.
Okay, well, thank you very much for this great evening.
Have a good night, everyone. Thank you for allowing me to be a part of this.
Thanks all.
Thanks. Good night.